apa-apa.
I won't block your.
It's fine. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, all judges and all the participants. My name is Rafa, one of medical students that affiliate also in pathological anatomy department. This is my case report. Our case report that tells about diagnostic accuracy of computed tomography (TTNB) and post-operative histopathology in thymoma. So basically, can you imagine everyone? Thymoma is one of a malignancy, one of neoplasm that grows from the thymic organ or glands. So basically, the thymic glands is one of organ that include on lipo soft tissue, and then also there's a lot of heterogeneity on it. So that's why to diagnose the thymic tumor, it's actually pretty unlikely to find the best which one is thymoma type, or maybe which one is it a thymoma, or maybe the other differential diagnosis. So, on the third guideline of WHO about thymoma, and then also the International of Thymus Group study, there's a one of development of the guideline that using Masaoka Koga grading, that every single year there's lots of consideration to pick which one is the best diagnosed. So for example, there's a lot of medical multidisciplinary like surgery or maybe pathology or maybe radiology as well, but sometimes we also consider first the patient come into the radiology. Okay, we need to do radiology first, and then perhaps we could do simply radiotherapy. Or the second scenario, if the patient comes to the general surgery, okay, maybe you need to do a surgery. So basically, the diagnosis of the thymoma is, and then the therapy is likely random as well. So this case description, a 54-year-old male presented with 2 history of cough. It's simply like subchronic cough. There's no protrusion about the neck. There's no sign other than related to cancer. So that's why the first initial modality that we use is only the radiology chest, simply radiology chest X-ray. And then after we see the result, it revealed a masses inside of the lung. So perhaps that is a lung cancer, or perhaps a small lung cell carcinoma, etc. And after that, we do a contrast CT. So why we do subsequent contrast CT? Because the CT is could define the location, the measurement, and every single need that to define. And then there's a well-defined lung mass, approximately 11.5 by 8.2 by 9.4 centimeter, located in the medial segment of the right middle lobe. Then the pathology also with the consideration with the radiology intervention and also the general surgery, we establish the diagnosis by the CT-guided TTNB or transthoracic needle biopsy. And then you can see here, there's a lot of polygonal cell and then spinal cell that this is really diagnosed that more into the thymoma, but we do not know which type thymoma based on the new guideline by WHO. And after that, the patient already agreed to do a simple resection, and then the resection, you can see actually the normal anatomy, it will be beautiful. There was a lobe, and then there's no morphological change, but you can see the lobe is unlikely same, right? And then also we can see there's 2 different color. This is more dark and this is lightning. So basically this is we call as lymphocyte rich and poor area. So this is really really support into thymoma A and B. And also we can see this, actually in normal of thymus, there's no epithelial cell, but actually we can see there's a lot of epithelial cell, but the description of the lymphocyte is abort. I mean, all of the preparate is likely see every single lymphocyte type C and immature. So that's why between the CT guided and then the biopsy, which one is the better? The answer is both of them. So that's why we could do arrange some guideline to make sure the diagnosis is way better. So that's is the implication for the clinical judgment after we know this is a thymoma AB type. So the conclusion, combination diagnostic approach incorporating TTNB and histopathology is essential. Thank you.
Benar? Silakan.
Only sopranic cough. There's no malaise, anorexia, nauseous, and it's simply a clinical manifestation to tumor or cancer. There's no. So simply like, there's also no protrusion on the neck. Yeah, just simply cough. And the patient come to the private hospital, so that's why there's a lot of examination room here. Okay, basically the thymoma is actually malignant, but after Masalka stage release, there is 1 until 4 stage, but the patient got 1 stage. What does it mean? The stage 1 is when we see the tumor, it's encapsulated with beautifully of capsule by fibro capsule. There's no infiltration to the maybe blood vessels or lungs or perhaps cardiomes, because simply the location is on mediastinum. So that's why the case of this prognosis actually is more way better if we do resection. Unfortunately, no, because actually we only brought this management and the case from the pathology group. So that's why we do not see any radiology.
Yeah. There is a question.
Yes.
First of all, the chest radiograph, mediastinal mass, and then
Yes.
CT stated that it is